Hello, thank you so much for taking time to join me today in the middle of your journey in the midst of the IECMHC symposium. It's really great and a wonderful opportunity to be with you guys today. I'm Allison Peak. I'm the executive director with Allied Behavioral Health Solutions. We're headquartered in Nashville, Tennessee. And so today I get the amazing opportunity to share with you guys the story of our utilization of reflective consultation for organizational well-being. And really in this space and time, hoping to highlight the ways in which we have found that reflective supervision and consultation really support organizational wellness and combat secondary trauma within infant and early childhood mental health services. So brief note about me. Again, I'm a social worker headquartered in Nashville. Really have spent the majority of my career centered around work for infant and early childhood mental health, both clinically and within systems development, and also within integrated behavioral health services and primary care settings. I do have the great fortune of being a founding member for the Association of Infant Mental Health in Tennessee, and also a member of the 2020 to 2022 Class of 0 to 3 Fellows. So really curiously in my career development, the process has been that I have long been a clinician, that I'm a social worker deep at heart, and have had the great privilege in the last few years of really working to develop systems and to set up organizations and programs in ways that I feel reflect core values of infant and early childhood mental health care. So it really is important when we think about the ways that things develop, and all things in the infant mental health world are relationally focused. And that is no different for the work that we do and for the conversation today. And so there will be lots of times and opportunities when I reference and use the word we. And when I say we, I really do mean we. Tennessee really benefits from a really strong relational perspective and a grouping of a number of organizations and associations that really enable, both through funding and volunteer efforts and coordinating workforce groups and all sorts of pieces to be able to move forward infant and early childhood mental health services across the state. Also, in beginning this story, I think it's really important that we set the frame and that we really talk about, what do I mean by infant and early childhood mental health? Patricia Van Horn with the University of California at San Francisco defined infant and early childhood mental health as the capacity to grow well and love well. And so really, when I think about that definition of infant and early childhood mental health care, I think about that as also referring to a continuum of services that support children birth through 5 and their caregivers, whether those be biological or psychological caregivers, to support relational health, safety, and healing in the events of trauma. And so that continuum of services could refer to everything from population-based well baby packets, to child-parent psychotherapy, to infant and early childhood mental health consultation, to evidence-based home visiting, and a wide variety of services in the in-between. But when we think about infant and early childhood mental health as a practice and as a discipline, we know that their core values really promote the use of reflective consultation for the purposes of supporting model fidelity for whatever program or project that may be, promoting relational emphasis of services, and for supporting the workforce in an effort to address secondary trauma. Some time ago, really, in thinking about how reflective supervision and reflective consultation all work together in the things that we do, I developed this graphic, which I refer to as the round of reflective practice, that really does talk about the interconnection between the multitude of words that we use to describe all of the ways in which we engage in reflective relationships. That really, in being in practice of reflective spaces and reflective supervision, when we're thinking about clinical work, in building capacity within leadership to engage in reflective practice as leaders, for supporting and building organizations that utilize reflective practices in decision making, in hiring, in disciplinary situations with staff, in building productivity and budgets and caseloads, and really building across the spectrum in all of the positions that those organizations hold, increased reflective capacity. So really wanted to, again, kind of anchor us to that as we start through our story, as we think about our time together and all the words that get used, the ways in which they're related, and the ways in which they might differ. For Tennessee, there have been a number of projects across the last 5 years really to develop and build reflective supervision and consultation through a variety of processes. We've done that with our Department of Human Services, our Department of Health, and then also with our clinical and mental health services sector. And within all of those, what we've seen is really incredible buy-in at the state level, backed by some level of funding. And so that funding you'll see there in those green boxes, again, green being that it alludes to this idea of cash, that these state systems have identified that reflective supervision and consultation is really important to the work being done, that they have put money behind that to say, we recognize and support the implementation of this practice. And then really what has occurred in a number of places, but really extensively within the clinical and mental health services sector, is that that funding then goes directly to providers and frontline staff. And so we see this kind of hierarchical jump in those gray boxes of folks who kind of get left out. That the state says it's important, that there's funds that come down, that there's a number of people who benefit, but that really the folks who are boots on the ground around the implementation of the reflective consultation, of the reflective supervision, often then don't get the opportunity to experience it themselves. And then that creates its own situation of systemic difficulties and of ongoing navigating relationships. And so what we saw as we really moved to implement a number of those projects were that we were finding breaks, that sustainability with organizational leaders really became a clear need. Specifically, what occurred was that we had a project to bring in evidence-based practices, and a number of those folks moved out of state. And so we had an organization who was essentially left without any sustainability around the process. That everybody that they had sent to this very long, extensive training cohort were gone. And there was no institutional knowledge. There was no historical experience to hold on to in an effort to build a next cohort. And so really we needed something that was going to allow for us to address longevity of models beyond frontline staff. It also became the place of being able to speak and recognize that frontline staff are not going to be in those positions forever. That even in places where workforce retention is really great and when we're hanging on to people for good chunks of time, the reality is no one's going to stay in that position for 25 years. Like we have to be able to hold on to those models beyond the duration of those frontline folks. Really thinking about increased fidelity to the model, and wanting for organizations to increase their own personal investments in the process. That we, for what it was worth, had asking them to come and have skin in the game, to be able to say, like, we're committed in a way more than we sent a couple of people and said it was okay for them to take time, but that really they were invested in the process and able to advocate for systems change. It also really became this place, and when we were looking at that kind of those level of gray boxes, that series of folks who were being missed out or being left out, that in that investment, we could identify who was consistently present and who was missing, that we knew we had people who were boots on the ground, who were really engaged with families, who were providing services, who wanted this reflective practice. And we had people in state decision-making positions who really were saying, we know the benefit statistically, we know the benefit from a systemic perspective. And so we wanted as well, but we knew that there were a group who were really missing. And that within that, we also really needed support for that sector of leaders, for those organizational leaders, in supporting them in identifying themes around addressing issues of race and equity, and also really considering who was at the table, but also one of our adages became not only who was there, but who also brought food to the party. Consistently, when it came to looking at organizations and systems, we had people who showed up, but they maybe didn't bring anything with them. And then we always had organizations and systems who paid for the catering and brought dessert too. So really being able to leverage that strong and clear investment from all the parties who were benefiting. So in 2019, really in recognition of kind of the breaks in the system, the places where we knew reflective supervision and consultation were not meeting needs, Tennessee developed what we refer to as the Tennessee First Five Training Institute. So this workforce development project seeks to build a high quality clinical workforce to provide dyadic infant and early childhood mental health services across the state. And we know that the vision's best realized when the support and development of clinicians is accompanied by the support and development of systems and leaders who embody infant and early childhood mental health core principles, reflective practice, and uphold fidelity to evidence-based practices. So our project really has two parallel training tracks, one for our clinical cohort, but then one very specifically designed for organizational leaders. And so our clinicians come out of 6 organizations that are selected each year, and those 6 organizations must identify 2 leaders from their respective organization who are going to participate in that organizational leaders training track. And so those organizational leaders complete pre and post metrics through what are called the Organizational Readiness for Change assessment. We call that an ORCA. They also get perspective planning, a reading syllabus, and bi-weekly reflective consultation. So this cohort at this point is 3 years old. And really, we've been able to take good data and really look at what reflective consultation at an organizational leaders hierarchy really is able to manifest and support at a greater perspective. The other piece about this organizational leaders cohort is that we're pretty clear at the front end that we need individuals with decision-making power. So we ask for folks not to send us program managers. Those are folks who really need good support, but they are not individuals who are able to make shifts in like budgetary decisions or to like realign productivity standards. And so we really are asking for leaders to come who have strong decision-making power and really are able to engage with us effectively in change. So after 3 years of these meetings twice a month, of this cohort who has grown together, and really who in the beginning communicated quite clearly and indicated that in many ways they were competitors over funding, competitors over contracts and grants. There was great anxiety coming into this reflective space of being able to share and be vulnerable when there were lots of varied perspectives and varied experiences in the conversation. And so qualitatively, what we heard back after 3 years was that folks didn't take into consideration the benefits of group reflective supervision for senior leaders because we usually get left out. We're doing our own thing and we don't have time for reflection. I went into it with a preconceived idea of what I was trying to get out of it for our teams, and we got so much more than that. It's a sense of camaraderie, being able to connect with others across the state. To have that support and really grow and understand infant mental health has equipped me to be a better reflective supervisor. When we do the organizational assessments, it's a much different picture than 3 years ago. And being able to see that growth has been great for us as an organization. And so what we heard qualitatively after 3 years was that this group really was able to identify that they could discuss hard things, that they had confidence in each other to be able to admit when something was going well and when it wasn't, that they felt less lonely as leaders and were better able to take empathic perspectives of those that they led because they had space and time to slow down, to consider alternative perspectives, to think intentionally about implementation of projects and products. This is one of those ORCAs that I referenced, and this is a pre and post ORCA from our first cohort. One of the things that the ORCA allows for us to do is plot answers on a map so that we're really able to demonstrate and assist in visualizing what change looks like across various sectors. And so the ORCA really targets systemic change around capacity for implementing change, current ability to implement fidelity to models, processes for addressing and implementing reflective consultation, workforce wellness strategies and what those may look like within the organization. And what we know, both for cohort 1 and for cohort 2, is that we have statistically significant change in 4 out of the 5 domains. The only domain where we did not see statistically significant change was in the domain around organizations' commitment to continued education and workforce development. Now, there are probably a couple of reasons to that. One being that organizations who are involved in our workforce development project probably self-select due to their own history and commitment in this area. Tennessee also has a really strong workforce development process through what are referred to as the Centers of Excellence. And many of these organizations consistently participate in those workforce development processes as well. And so we anticipate in that cohort or in that category, we really had a bit of a ceiling effect. But what we know is that this opportunity for leaders to slow down, to think together in reflective space, to consider and collaborate around issues that are arising, like workforce retention and reimbursement rates for the state, and new grant projects coming down from various state departments, allowed for a sense of relationship, decreased stress, allowed organizations to really think through and implement alternative interventions and supports for their staff, to really consider and hold the increased stress that came with COVID and addressing shifts to telehealth and personal anxieties and fears in the midst of the greater systems shifts and changes. We also saw with the data outcomes a parallel process that clinical and leadership cohorts demonstrated growth in clinical knowledge with organizations that demonstrated growth in organizational capacity. That there really was a parallel process that when one did well, so did the other. We also saw clinicians whose organizations participated consistently in reflective supervision and consultation reported awareness that their leadership was participating in that activity and a sense that the leadership was engaged in their process of learning and growth, that they felt as though this really was an organizational investment, that they really felt as though that this was a positive experience across the agency. We also know that leaders who participated consistently in reflective consultation were most likely to have clinical cohorts who participated across multiple years of the project. So that when leaders were engaged, we saw them come back year over year. When leaders were less engaged, we were more inclined to see them not participate year over year. So, major takeaways from our story. We know that reflective consultation with organizational leaders has the ability to promote healthy workplace culture, to allow for the opportunity to think of and think through what we refer to as the ghosts in the agency, those forces, those beliefs, those reasons that years ago may have resulted in a current policy or a current attitude towards a certain situation. That this reflective consultation promoted program sustainability and really protected the importance of reflective consultation for providers, that those leaders were more likely to advocate for, to support, to ensure that reflective consultation happened, that it was consistent, that it was available, that it was regular, routine, reliable, all of those things we talk about as being so important. That it really supported intentionality for programmatic shifts and changes. There have been a number over the last 3 years. There's no escaping that. All of you who are listening to this story have had your own programmatic shifts and organizational changes. Those have really been required in this place that we have all lived through in the COVID pandemic. But the reflective consultation allowed us to slow down and think about it, be really intentional with it, and also really promoted empathic and relational leadership styles. So we're pretty excited about the work and the data that's coming out of that work and about the impact that it's had on Tennessee systems. If you've got questions or you're curious about things about our story, about how we moved from A to B over the last 3 years, feel free to reach out, send me an email. I'm always happy to talk. It's always lovely to be with you all. Have a great rest of your day.